So the update, as you rightly pointed out, is 81. Of those 81, 66 are due to transmission within Lagos. We have an additional 15 cases that came off a vessel that was maneuvering off the coast of Lagos, doing some oil and gas work, and that ship had a positive case. We airlifted the positive case off the ship, and we went back to test the 51 crew of the ship, and we initially found 7 positive. We removed the 7 from the ship to Yaba, and the company has isolated the remaining 44, and of those 44, another 8 have tested positive. So we will have a total of 15 from that vessel that is off the coast, that came in off the coast of Lagos. So that does not represent transmission within Lagos. So we're removing 15 from the 81, otherwise it will give us a false impression of what's going on in Lagos. So we only had an increase of about 8 new cases over the last 2 days. Of those 66 that are in Lagos, we're still contact tracing those that came in by air, and we are just about getting to the end of the 14-day surveillance. For a lot of people are coming off the contact tracing list from the imported cases, but we're contact tracing the contacts that are arising from the in-community infection. And those contacts are much less than the imported cases, because in the imported cases you will always have the manifest of the airline as well as the contacts that they've had when they were on ground. The question around severity, most of our patients are experiencing a very mild to moderate degree of illness. In fact, we don't have anybody that's requiring ventilation at the moment, which is a symptom of what we would describe as severe disease. So if we were to put some percentages on those 66, I would estimate that about 33 of the 66 are mild, and about 33 are showing moderate disease, just characterized by severe fever, feeling weak, some coughing, and headache and body pains. But it is not extending to affect the organs such that we have lung failure or kidney failure. So we haven't seen any of that yet. I'm not aware of Chief of Staff's itinerary, so I don't know where he is. We WhatsApp, but from WhatsApp you can't tell where somebody is. So we're exchanging information. I haven't asked him his location. He seems well and happy. We are exchanging information on strategic issues. And it's been a long time we talked about his health, so I presume he's made a full recovery. The 16 students that were retrieved from the border, further information, they were coming from a boarding school in an area of Benin Republic that has not seen any COVID-19 transmission. So they were handed over to us at the border. We organized a vehicle for them, determined that they were of no risk. So they were rapidly tested and moved on their way. They came from around Kano State. They were in a rush to get back to Kano State to avoid the interstate border restrictions. Mr. Governor saw them, greeted them, had some words with them, and gave each one of them 50,000 naira to help them on their way back home so that they can return to their families quickly before the state border interruption would kick in. We still have excess testing capacity. We have 3 reference laboratories in Lagos, one at Yaba, one at Luth, and one at Nigerian Institute of Medical Research. Each of those facilities is testing about up to 50 per day. So if you add that up, we have about 150 tests per day, and we're increasing that capacity by the day. So hopefully we'll be able to get to 200, and soon we might be able to get to 300, and so on and so forth. We are not using rapid tests at the moment because I've explained several times that rapid testing is inaccurate, and unless we can validate and be confident about the results we're getting, we will not be deploying rapid tests because they will have severe consequences if we are misdiagnosing patients. We would rather escalate our molecular biology tests, which are harder to do, more expensive, more time-consuming, but at least when we do that test, we know it's 100% accurate. Either the virus is there or it's not there. It also helps us to determine whether a patient is no longer contagious. And that is very important for us to determine when we can release a patient back into community. Regarding the JACMA donation, it has gone to Abuja, and in Abuja it will be apportioned into the needs that the states have. Lagos State has capacity at the moment, so we will receive our portion of that donation when the state government has allocated our portion to us. So we're not under stress in terms of access to PPE or to testing capacity, and we know in due course that we will get our portion from Abuja. Thank you.
Okay. Hello. Let's take it one by one, please.
Sorry, your distribution was published already. I don't have it on me. It was published already. So you can ask your colleagues if they have it.
Good afternoon, sir. I'm Mary Alala Yusuf from Channels Television. Looking at the figures of cases and people who have recovered, the world recovery is at about 20% of those who are positive. But in Nigeria, we're having something just short of 6%, which is very low. I want to know if there's any reason for this. And then in answering your last questions, you spoke about a 14-day period there. So are we expecting more people to be released real soon, since 14 days is like our window period for waiting? Then secondly, could you give us some details about the second person we lost to COVID-19?
Okay, let me clarify. Oh, sorry.
Good afternoon, Honorable Commissioner. My name is Tokumbo Yetunji of Arise TV. I have 2 quick questions. First one, how prompt are patients that are taken to the hospital being attended to? Because there is a viral story of one of the survivors discharged yesterday, talking about having to stay at the hospital for hours, and even another one saying he had to stay sleep on the bare floor for about 2 or 3 days before, he could be attended to. And that even those that are supposed to be the personnel attending to them, they were kind of skeptical because they didn't have enough protective, wares and all that to attend to them, that they sleep their drugs and their food under the table for them to pick, treating them like, lepers. Second one, sir, if you move around the neighborhoods these days, especially since, this is the first day that the total restriction is taking place, and I've moved around. I've seen youth, young men especially, gathered in groups, playing football. Probably, taken from the global trend of young people thinking they are invincible, the virus is not for them. What are we going to do to curtail this practice? Thank you, sir.
The last one for now.
From my own observation, I've been able to deduce that medical workers can also spread this virus if they are not well protected. They can also spread it through their families, going back home to their families. So what is the strategy? Is there a plan to, isolate them as they treat others? And do you also have plans? I mean, the government, are there plans for them to be, compensated? Some form of stipend for them?
Okay, the general survival of COVID, or let's talk about the mortality rate, is variable from country to country. On average, in China, it was 2.5. In Italy, it appears to be in a certain age of 5%. In other words, 5 out of 100 people will die of COVID in some parts of Europe. 2 to 3 would have died in China out of 100. So the fatality is still very low. We expect most of patients to survive. In Lagos, out of our 66 that are from Lagos and including our 15 off the ship, nobody has died. We have 100% survival. We've discharged 8, and there's nobody on the ward that is looking like they're going to die. So as I said earlier on, we don't have severe disease yet amongst the patients we have. All of them range between mild to moderate illness. So our survival in Lagos so far is 100%. 100 out of 100 are still alive. And out of those patients, we've discharged 8 fully recovered. And we will soon be discharging in the next week as their tests come back negative. Remember, I said we have to have 2 negative tests, because if you have 1 negative, sometimes you become positive again for a few days before you become fully negative. So just to protect the community, we're making sure that you have 2 consecutive negative results. Regarding attention, I'll say this and I keep saying it over and over. Isolation is not a normal hospital. An isolation ward is a specialized unit where patients are received that have highly infectious diseases. That means that the staff who are specially trained go through a very elaborate process of receiving the patient from the ambulance and transferring them to the ward. That admission process alone can take up to 2 or 3 hours because the staff have to put on appropriate gear. They have to go through a spray down process. They have to admit the patient. They have to take a sample before they go on the ward. They have to go on the ward, then they have to be bedded in the ward, and there has to be some psychosocial treatment because you're going into an isolation ward. It is not a normal ward. That's why it's called isolation. I'll allude to that a bit more in terms of the fact that a normal ward, you're accustomed to seeing people walking around up and down, staff, doctors, cleaners. In an isolation ward, you don't see anybody. All you see is your fellow ward mates. The doctors and the cleaning staff will come in for a very short period of time, a few times a day, and they will leave. Because the longer they stay there, the more chances are that they will get infected themselves. So that is precisely the nature of the ward. And it takes a few days for patients to become accustomed to the environment of isolation. And that's why it's called isolation. So for about 1 or 2 days, the patients will always complain on social media. Nobody's come to see me. Nobody's done this. I haven't seen anybody. That's not correct. They're just not accustomed to seeing people for a few minutes, a few times a day. It's totally different from a normal ward. And that, after about 2 days, the patients become accustomed to that, and then they settle down. They start to interact with other patients on the ward. They make friends, and if you've listened to the testimonies of patients that have been released. They thank the government. They've made lots of good friends. They're happy they're well. And they finally understood what isolation means. They've called, I saw one video of one of our American guests who said, it's a waiting game. And that's it. It's a waiting game. And you're isolated because we have to ensure that you're not infecting community, but also ensure you're not infecting the staff. If we lose our staff, then who is going to look after the patients? So we can't, doctors don't go into an isolation ward and just hang around. They go in, do what they need to do, and they leave. Same thing with people that deliver food. They go in, do what they have to do, and they leave. Patients are not accustomed to that. And besides, they're behind personal protection equipment, so you can't even see their faces properly. It's an environment that is a very unusual environment, which is why we give them psychosocial support, usually through their telephone, smartphones. I think the patient you're referring to is a patient that turned negative, and his subsequent test was positive. So he was anticipating that he would be discharged, but his test turned positive, the second one turned positive, so he had to be kept in for longer than he thought. So until he got another negative result, and then another negative result before we could discharge him. So I think the information you're receiving is about a prolonged period between a time when we said he could be discharged and a time to which he was actually discharged. And that is all done in the nature of protecting the environment to make sure that when we release a patient, the community is safe and that he's no longer contagious. You know, a lockdown can never be 100%. What we're trying to do is just slow down movement. As I said earlier on today, as another press briefing, we're just trying to avoid two random people coming into contact with each other. That's what we're doing with social distancing and lockdown. So why must we stop two random people from coming into contact with each other? Because many people with COVID-19 don't have any symptoms, but yet they're secreting the virus. So the way of stopping this outbreak is just to, for a period of time, to avoid two people literally coming within 2 meters of each other or touching any surface that somebody else has touched. So a lockdown is just essentially to grind down movement in a city, to minimize it to as much as we can. It will never be 100%, but our job is just to slow it down to as much as we can. We don't want to come out with, you know, security brutality. We don't want to demonstrate. This is not a military state. You know, we're a civilian democracy. Children will be children. We discourage it, and when we see it, we would advise against it. But also, you know, as civilians, we must play our part in this whole process of lockdown and social distancing. As I've been explaining, the medical personnel that are looking after the patients are at risk. Because they're coming right into contact with patients, they have to go through special training. They have to wear special protective equipment. They have to understand how to move around in a ward. And the shorter the time they are in the ward, the better. Because as we know, this infection can be airborne. So as long as you're breathing, you're at risk if you are in the vicinity of a patient that is positive. So that's why it's an isolation ward. And that's what patients are not accustomed to. Because the doctor will come in, he will examine you very quickly, he will have few words with you, and he will leave. And patients do not understand that. So after he's left, we will call them on their phone and we will explain certain things. And it takes up to 2, sometimes 3 or 4 days for patients to become accustomed to that situation. We have an HR plan, a human resource plan for all our staff. They have hazard allowance, insurance, and all kinds of support incentives to make sure that we're compensating for their dedication and for actually risking their lives looking after patients on the wards. It's a very hard job. It's very risky. Not many people want to do it, but we're doctors. That is our job. We're on the front line. That's what we trained to do. That's what we signed up to do, and that is what we will do.
My name is Amina Telegushi, health correspondent, Lagos Television. Firstly, you've answered my question on the condition of the functioning isolation center, but I want to ask the health practitioners. We know no government in the world has enough health practitioners to handle issues, but now we don't know what is the situation of our health practitioners now. Like you said, all of those people go through training. It is not just an ordinary health practitioner that can handle, cases with high risk of pathogens. So is the government looking at accepting volunteers, all angle, both health, HR and all of that? Are they hoping to get that? Is there any plan to do that? Should there be a huge outbreak? Thank you.
Okay, the last question. The last question, please. May I take it?
I don't know if you got me. Thank you very much. It's interesting that you mentioned that you can get a positive result after getting a negative one. And also that you use a very sophisticated method of testing. We've heard reports from other countries of people who were discharged and became positive again after being discharged. So my question is, with this method of testing, should people be wary of people who are discharged, or is it a foolproof discharge, so to put it?
Honorable Commissioner, sir.
Okay, regarding healthcare professionals, we have 27 general hospitals and almost 300 primary healthcare facilities and a teaching hospital. So where Lagos is well endowed with medical practitioners in the public sector, we have a large number of medical practitioners or healthcare professionals in the private sector. Yes, there is a shortage in Nigeria, but generally Lagos is doing much better than any other state, because people tend to migrate to Lagos before they migrate out of the country. So we are not struggling at the moment with healthcare professionals, either nurses, doctors, or ancillary support. And yes, we're receiving volunteers. People who have gone into early retirement are coming back. People who are allied healthcare professionals are coming back. They're going through training. We're training every day, Monday to Friday, sometimes over the weekends. So we're training several tens to hundreds of practicing practitioners and those that are volunteers. And the volunteers can be cleaners, they can be assistants. There are all kinds of people that go into the ward, and all of them require training. So far, we're doing quite well. We're preparing for that 100-bed facility at Onikon that requires almost 50 to 60 personnel that are being trained right now. They will complete their training tomorrow. Then they will go for certification, and then they will be deployed to that facility. And as our facilities come on board, we're already anticipating what we need for those facilities, and we're training ahead of time. Yes, we have 3 laboratories. They are molecular biology laboratories. That's the only laboratory where you can get 100% accuracy. I explained that already. We plan to increase the capacity of each of those labs to over thousands. But it takes time. It's a stepwise process. And we are ahead of the outbreak. So we have excess testing capacity. With every day that passes, we are increasing our testing capacity. So far, I think the rate of positivity is still very low compared to what we've seen in China and in Europe. In China and Europe, cases were going up by the hundreds every day till they reached the thousands, and then they started going up by several hundreds per day. Our strategy is effective. The strategies that we're deploying in Lagos, we're only seeing between 6 and 10 positivity a day. That's a very, very slow rate of increase compared to what we've seen in Europe and around the world. In America and in England, you've seen how the numbers have gone into the thousands in 1 or 2 weeks. We're still under 100. And every day we're creeping up, and every day we're discharging. So it's plus, minus every day. And we're not seeing, because of the strategies we've deployed, we're not seeing that steep a rise. So we are definitely confident of our strategies. We're confident that even if we do see a surge, it's definitely not going to be as much as we've seen in Europe, Italy, France, Spain, places like that, because we've had a very early start. We've been very aggressive. We've been on an offensive approach, making sure that we contact trace aggressively. We have refused to use home care. Everybody we know that's positive is removed to an isolation facility, thereby reducing the risk to community. And we plan to continue that very aggressive approach until a point where, if we get there, we would have exhausted our bed capacity in all our 27 general hospitals or our tented facilities that we're building every week. I don't think that I think that we're keeping ahead of the outbreak, and unless there's a very, very dramatic rise in the situation, and unless the community don't follow the instructions that we put out there, if you're practicing social distancing, we should automatically see a slowdown and a flattening of the curve and eventually a reduction. So we can only put out the information. It's up to everybody really to follow the instructions. Our job is to admit positive cases and to give you the information that will help you to protect your environment. When we talk about becoming positive after a negative, it's nothing to do with the test. In fact, the test, that is showing how sensitive that test is. If you've turned negative and the following day you turn positive, it means you've started to secrete small amounts of viruses again. That is a reflection of your immune system, nothing to do with the test. The test is actually picking up very, very, very small amounts of viruses. As you get better, the virus load goes down every day to almost the point where we have the capacity to pick one single virus. If it's there, we'll pick it up. When you're at the height of your infection, you can be secreting billions of viruses. When you're discharged, you shouldn't be secreting one. You should be secreting nothing. So when we give you a negative, the next day, maybe you didn't sleep well, your immune system drops a bit, you then secrete a couple of viruses. We will pick it up.